All right, hello. Welcome to the ventilator management portion for Apollo MedFlight's orientation process. My name is Damon Crabtree. I'm the lead field training officer and a flight paramedic here at Apollo MedFlight. As always, you can reach me by email, damoncrabtree@apollomedflight.com, or by phone, 806-206-8015. Call, text, whatever you need to do. I'm pretty much available around the clock to answer any questions or to help out as needed. I just want to start off by apologizing. I'm having difficulty viewing my notes, so you're going to get to see kind of the background slideshow for this entire presentation. So what we're going to do today is we're going to talk about two vent strategies. One is lung protective and the other one is obstructive. After that, we'll discuss a little bit about alarms. This lecture is not going to be crazy hard. I actually think it's extremely simple. We just aren't taught in a streamlined fashion. Whenever we put patients on the ventilator, it doesn't make them better. Most of the time, it's going to make them worse unless we continue treatments and we optimize our ventilator settings. So the whole do no harm is extremely imperative for us whenever we're doing vent management. This strategy wasn't developed by me. I'm not a smart person. I always say I just memorize stuff that smart people say. This was developed by Scott Weingart at the MCRIT podcast. I've simply taken what he's taught and opened up for free open access emergency medicine and applied it to our environment and made a couple of changes here or there to better fit what we do. So I'm just going to start off with the evidence because we are going to be teaching you something that isn't typical for most people's vent management classes. Now, the evidence has been out for years, but it's been a long time coming for us to get to a point of changing our minds in the transport environment, especially in EMS, of doing it this way. So I'm going to do my best to try to help facilitate that. There's three major papers. The top one is just kind of an op-ed that Scott Weingart wrote. It's a couple pages long that was released in ACEP's journal, and all it is just going to be 3 pages of him explaining what we're about to go through. The next two are really where the bulk of the evidence for this strategy comes from. 2000, ARDSNet released a paper showing that higher tidal volumes, 10 to 15 mils per kg, were extremely harmful for patients that had acute lung injury and ARDS. And then the bottom paper was released in 2010 in critical care. It showed that even for patients without acute lung injury, without ARDS, high tidal volumes were injurious and causes the issue. So even if you intubated me right now, where hopefully I don't have any sort of lung pathology going on, if you gave me that 10 mils per kg tidal volume, it would injure my lungs over time. So the strategy that we're going to teach is a low volume strategy. So a couple resources. This is based off, again, Scott Weingart's lectures, Spinning Dials, How to Dominate the Ventilator, Parts 1 and Part 2. You can get online and you can find both of those. And I definitely encourage you to watch them several times. He speaks much more eloquently than I do, and obviously he has a ton more experience being a physician in the critical care environment. Aside from that, his MCRIT podcast is amazing, and you're going to find a lot of resources there to shed some insight on how we can improve for our inpatients. And then finally, ARDSNet. ARDSNet studies critical care interventions and hemodynamics, especially with ventilator management. So they're the ones that came up with the bulk of all this strategy. They're the ones that did the randomized controlled trials showing that low tidal volumes are better than high tidal volumes, and then how to adjust your other settings to compensate for that lower volume. All right, so there's two strategies, lung protective and obstructive. The obstructive is going to be our asthma and our COPD patients, and that's those patients with acute pathology of bronchoconstriction. Everybody else is going to receive the lung protective strategy. ARDS, bilateral pneumonia, congestive heart failure, intubating, anybody for any reason, they'll get lung protective. That's what that third paper on a couple of slides ago showed, is that even if they don't have that lung injury already going on, they're going to develop it if we give them really high tidal volumes. We're going to start with the lung protective strategy. It takes a little bit longer, a little bit more in-depth discussion, and then after that we'll get on to the obstructive. So a couple of things you have to know. Every ventilator usually has multiple modes that you can set your patient on. For this strategy, we're just going to use one, and that's going to be assist control volume. Our ventilator at Apollo, we generally use the Zoll impact vent, which has assist control SI and V with the option to have volume or pressure regulated breathing. Assist control volume, what that's going to do is whenever the ventilator is cycling, and it's going to be on a timer, it's going to give all the settings that you input. So it's going to allow you to input tidal volume, respiratory rate, IDE ratio, and your FiO2 and PEEP. So if your patient's extremely sedated or they're still paralyzed from the intubation, and you set the tidal volume to 10, or excuse me, the respiratory rate to 10, the patient's only going to receive those 10 breaths over a minute. If your patient starts to wake up, their sedation begins to wear off, and they start over-breathing the vent, what's going to happen in assist control is if they have a spontaneous breath, the vent is going to recognize that they're breathing, and it's going to completely take over that breath and give whatever tidal volume, PEEP, FiO2 you had set for it. That's contrary to SI and V, which means synchronized intermittent mandatory ventilation, where you're going to be able to input all the same stuff, but whenever the patient begins to wake up and starts over-breathing the vent, it's going to try to synchronize with the patient. So if you give a breath and then there's a 4-second gap and then there's another breath, if the patient decides to take a spontaneous breath, right in between that, the vent's going to recognize it, and it's just going to allow the patient to take whatever tidal volume they want, and it's just going to add the PEEP and FiO2 that you preset. So there's not really much difference, because most of the time in our environment, we're going to have the patient really well pain controlled and well sedated, because they're going to wake up easily because it's loud, it's vibrating, and it kind of jolts them around. So we have to kind of keep them heavily sedated during transport. If they're heavily sedated like that, then there's not really going to be a difference between the two modes. There's never been a study to prove any patient-important outcomes between assist control, SI and V, and any other type of ventilator mode. So assist control can lead to pretty quick hyperventilation if your patient isn't sedated well, because every time they trigger that breath, it's going to give the full tidal volume every single time. So we do have to be on top of sedation, pain control. So that's what assist control is. The volume component gives you the choice between volume and pressure. If you have it set as volume, which you should do a majority of the time, then it's going to allow you to set your tidal volume, which is going to be very important for this lecture. And all you do is you monitor pressure with every breath. So it's going to pop up peak inspiratory pressure with every breath, and you just monitor that your pressures aren't getting too high. Conversely, if you set it at a pressure, you would set whatever pressure limit you wanted, and then it's going to give volume up into that pressure. So you would have a set peak inspiratory pressure of 25 or so, and it would have varying volumes with every breath. So it doesn't really matter which one you set, because you're going to be monitoring both. If you set volume, you're going to monitor pressure every breath, and if you set pressure, you're going to monitor volume every breath. So there's 4 dials that we're going to have to spin, and each one has its own certain reason for adjusting it. So this approach is going to break 5 different settings into 4 different knobs, and kind of streamline our thought process whenever we have an issue on the ventilator where we're trying to do something. We know there's just one setting we have to go change for that, as opposed to, I know it's been taught, if you have high end-tidal CO2, you can either increase your respiratory rate or increase tidal volume. Well, because we're doing this low tidal volume strategy, we're going to have an upper limit on the tidal volume for every patient, and the patient's going to change, and we're going to change our limits as the patient changes. So we don't have that luxury of moving up our tidal volume to help blow off more CO2. All right, so our 4 different components are going to be tidal volume, inspiratory flow rate, respiratory rate, and then FiO2 and PEEP kind of combined together. So number 1, tidal volume. We're going to set tidal volume off of 6 to 8 mils per kg of predicted body weight. So if your patient looks like a Michelin Man and they're 5'2" and 500 pounds, we're not going to give tidal volumes based off of that 500 pounds. We're just going to use a predicted body weight scale or a predicted body weight formula in order to assess what that kind of looks like. Whenever patients get bigger and become more and more obese, their lungs don't grow. They actually get worse and worse the larger they get. So this is what a predicted body weight scale looks like. You can find on the left side height for females out here to the left, and then all it's going to do is it's going to tell you your predicted body weight for every single height, and then it actually, this scale gives you 4 through 8 tidal volumes for each predicted body weight. Same thing for the males. Easiest thing to do is just find it on Google, save it to your phone. There's several apps out there that you can use to estimate predicted body weight. What I do is I just kind of memorize this formula. So for men, predicted body weights is going to be 50 plus 2.3 times height in inches minus 60. It seems kind of confusing, but we'll go through an example to show. It's pretty intuitive. And then for women, it's going to be the same formula, but their base rate instead of 50 is going to be 45.5. So we'll do a male tidal volume real quick. Say we get a 5'7" male, that's going to be 67 inches. So if we input into our formula, 50 plus 2.3 times 67 minus 60. So the whole point of what's in that parenthesis is how far over 60 are they? So how many inches over 5 foot is this patient? So for us on this example, that's going to be 7. So 7 times 2.3 equals 16.1. And then we're going to add 16.1 plus 50. And that's going to give us 66.1. So we're just going to round it to 66 as this patient's predicted body weight in kilograms. And then to find tidal volume, because we're going to use 6 to 8 mils per kg. And for every patient, you're just going to start at 8 mils per kg and work your way down if you have to. So 8 times 66.1 or just 66 equals about 530 mils for a tidal volume. So that's a 5'7" male. It doesn't matter if he's 66 kilograms, if he's 50 kilograms, or if he's 250 kilograms. his lungs are going to remain the same size in his chest. Your lung doesn't add tissue just because you get bigger. So this is just a CT scan of a patient with what looks like probably pretty bad ARDS and pneumonia. On the bottom of your screen right here, this is almost half of the lungs bilaterally that are dependent lung portions, as in they aren't receiving any tidal volume. So whenever you give this patient a breath, that 8 mils per kg isn't going to anything down here on the bottom. It's only ventilating these top alveoli that are still accessible for the air to get down to. So that's why this low tidal volume is necessary, especially in these critical patients. They already are extremely sick, and these bronchioles and alveoli are filled with pus or mucus, and now we're going to add on, even more pressure to these upper lung portions, and then eventually we're going to blow out these good alveoli, and then these bad alveoli are just going to sit down here and never even be involved in ventilation. So the tidal volume knob is going to equal protection. It's going to be what we change in order to help the patient be more protected so they don't develop ARDS or any other type of acute lung injury. What tidal volume isn't is ventilation. We're not going to increase tidal volume because our end-tidal CO2 is high. There's going to be another knob for that in a minute. So what does protection mean? We're going to do an assessment on the ventilator in order to determine if the pressure is too high at the alveoli, and that pressure is going to be plateau pressure, which we'll go over in a little bit. So the next knob we're going to move to is inspiratory flow rate. Usually inspiratory flow rate is going to be 60 to 80 liters per minute. And what that means is if a patient has a tidal volume of 500 and we set them on 60 liters a minute, every breath is going to go in over 0.8, 1 second at a time. We don't have the option on the Zoll Impact to see inspiratory flow rate. So what we're going to do is we're going to change our inspiratory time as necessary. So both of these, the main function of it is how quickly is the patient going to receive the breath. Whenever the patient's on the ventilator, especially our transport ventilators that don't have these kind of new age components that some of the new ICU ventilators have, is the patient's going to be triggered off of a time cycle. And whenever the ventilator decides to give that breath, it's just going to give all or nothing. So if we set our inspiratory time to 2 seconds and the patient has some level of awareness, they're going to get this long, drawn-out breath, like shh, as opposed to an inspiratory time of half a second, where it's going to go in and be shh, and they're going to get the same tidal volume. One's just going to be long and drawn out, and the other one's going to be quick and to the point. That's different from what we do. So if you decide to take a big breath right now, like I'm going to do, at the very beginning of that breath, you have a very high pressure difference between the outside environment and what's in your lungs. Spontaneously breathing, we have nice negative pressure breaths. That's because our diaphragm contracts, moves our abdominal organs out of the way, our lungs follow behind that, and all of a sudden there's a negative pressure within the lungs and air rushes in. When it rushes in, it's going to rush in at a very high rate at first, and as your lungs fill up, it's going to slowly taper off. So that's called a decelerating flow or decelerating ramp ventilation. Some of the ICU ventilators have that. That's what the patient would be most comfortable on. But since we don't have that ability and it's all or nothing, for us on our ventilator, the patient's going to be more comfortable getting that breath all at once, a lot quicker, as opposed to long and drawn out. Long and drawn out feels like you're holding the breath from them, and they'd rather you just give it all at once. If your patient is sedated well and have good pain control, and they're not, super aware of what's going on, this dial doesn't really matter that much. This dial becomes important whenever you have your patient, with RAS score of, -1, or let's say like a GCS, where I could say, hey, Damon, and they open their eyes and can give me the thumbs up. If we're, getting our patients to that level of sedation, then this becomes important, because if your patient looks uncomfortable, it's probably because we're not giving the breath fast enough for them. But in our environment, again, they're probably going to be sedated pretty heavily, because it's going to be loud and vibrating a bunch, and they're going to easily wake up. So if you had to forget something, this is the least important for this lung protective strategy. So just know our inspiratory time, we're looking for 0.5 to 2 seconds. If the patient looks uncomfortable, we're just going to decrease that time so they get the breath a little bit quicker. So tidal volume equaled protection. Our inspiratory flow rate or inspiratory time is going to equal comfort. We're going to decrease that to make the patient more comfortable if they need it. The third dial we're going to look at is respiratory rate. So this is going to involve a little bit of number crunching for us. In order to find respiratory rate, first we have to determine what the necessary minute ventilation is. For us, just sitting here spontaneously breathing, not running around or doing anything crazy, you're breathing 60 mils per kg per minute of volume. Whenever you get placed onto the ventilator, that instantly doubles to 120 mils per kg in order to account for the added dead space from the tube, from the vent tubing, from the ventilator itself. So how does that work out? If I'm 70 kilos and I'm sitting here spontaneously breathing on my own, 60 times 70 is going to equal 4,200. And that's the amount of air I need to come into my body every minute to maintain eucapnia. So a CO2 of 40, or CO2 of whatever I'm at this time, that's what I'd have to maintain. Again, we get put on the ventilator and that doubles. So it's going to be 120. So 120 times 70 equals 8,400. So 8,400 is what a 70 kilogram patient is going to need every minute to maintain eucapnia. So this is about respiratory rate. So how do we find respiratory rate? The formula for respiratory rate is going to be minute ventilation minus whatever tidal volume we're giving the patient. So my minute ventilation was 8,400. If my patient's 70 kilograms ideal body weight or predicted body weight, so 70 times 8 equals 560. 8,400 divided by 560 equals about 15. So our breaths per minute that we're going to want to start this patient at is 15 breaths a minute. Generally, you don't always have to do that calculation. The whole point is to not put a breath rate of 10 or 12 a minute on these patients, because they're going to get hypercapnic pretty quick. What I do is, if it's not a asthma COPD patient, because we'll get to that in a minute, which has a little bit of a different strategy, every patient just gets put on 16 or 18 breaths, and then we're going to monitor in-tap CO2 from them. So, recap: tidal volume equals protection, inspiratory time equals comfort, and respiratory rate is going to equal ventilation. So if the end-tidal CO2 is high, we're going to go up on our respiratory rate in order to blow off more of that CO2. if the end-tidal CO2 is low, so if it's less than 35, we can't really lower our respiratory rate. The reason that is for the limitations of end-tidal CO2. There's a couple of different components, but one of the components is perfusion when it comes to your end-tidal CO2 levels. So if you have a low end-tidal, then we're just going to set them on 16, 17, or 18, and then you have to get an ABG to prove what that CO2 is, because there might be a gradient between PA CO2 and end-tidal CO2. The whole point, if it's high, then you can believe that the CO2 is high, because the end-tidal is always going to be lower than whatever your true PA CO2 is. So if our end-tidal is high, we know we can blow off some of that. If it's low, we can't know until we get the blood gas. So don't start dropping your respiratory rate because you have an end-tidal CO2 of 20. The only reason that you'd want to drop your respiratory rate is if you had them at an end-tidal CO2 of 50, you increased it to a breath rate of 20, and now you knocked them down to 20. You actually witnessed yourself doing that. That's the only time that I would lower respiratory rate for this strategy. Besides that, I keep them at 16 and get a blood gas if I have that option. So on top, I know that glucometer's upside down and it actually says 298, but pretend with me that it says 862. So it's like a DKA patient. Our DKA patients are going to have that Kussmaul breathing because they're acidotic and they're trying to compensate with respiratory alkalosis for their metabolic acidosis status. So every DKA patient you see, they're going to have high tidal volumes, high respiratory rate, which is causing them to have a really profound minute ventilation in order to keep their pH from dropping way too low. So earlier we said spontaneously breathing people, they get 60 mils per kg. Once you put them on the ventilator, that's going to necessitate 120 mils per kg. And if you have an acidotic patient, they're going to need to double that again for 240 kg per minute. This is going to work with your DKA patients, with any acidotic patient. So severe aspirin overdoses, TCAs might cause it, toxic alcohols. The whole point of an acidotic patient is if you are forced to intubate them, you'd want to keep them at whatever CO2 level they were at prior to the intubation or prior to them decompensating if they became apneic or whatever the case may be. So if I had a 70 kilogram patient, 240 mils per times 70 equals 16,800. And then if I went and divided that by my tidal volume of 560, so 240 times 70 equals 16,800. Excuse my handwriting. Again, I would define respiratory rate. I take my minute ventilation and I divide it by my tidal volume. Tidal volume of 560 for this case. And my initial respiratory rate is going to be 30. 30 is going to be what I need to get them started to keep their end-tidal CO2 low, like they need it to be to have respiratory alkalosis. What I'm going to do is go up from there if needed. So if I have a DKA patient whose end-tidal was 18 prior to sedation intubation, I put them on a respiratory rate of 30 and I immediately start monitoring their end-tidal CO2 level and it starts to creep up, then I'm going to keep going up on my respiratory rate to 34, 38, 40, as high as I need to go to keep them at that level until we maintain until we treat this acidosis and allow them to come up on their pH appropriately. All right, and the fourth and final dial is going to be a combination of FiO2 and PEEP together. The FiO2, easy, it ranges from 21% to 100%, and PEEP goes from 0 to however high you want to go, where you feel comfortable going. So how this is going to work, if we intubate a patient, immediately we're going to want to put them on the ventilator, and we're going to put them at an FiO2 of 100% and a PEEP of 5 for this lung protection strategy. We're going to give them 5 minutes, allow them to recuperate from possibly getting hypoxia during the intubation. 5 minutes in, we're going to drop them down to an FiO2 of 40 and a PEEP of 5. Same thing, if your patient's already on the vent, most of the times you're going to show up to where they're still at 100% or they're still really high with no PEEP involved. And I'm just going to pick a spot on the PEEP scale that I'm going to show you on the next slide and assess from there. So let's imagine that we intubated the patient. They're on 100% and they're on a PEEP of 5. Well, 5 minutes into it, I'm going to drop them down and immediately drop them down to this level right here. This is the ARDSNet PEEP scale. They studied this and then even a higher PEEP scale and showed mortality benefit, which isn't very common with ventilator stuff, to actually find something that actually helps patients survive. So what's going on here is it's forcing you to change them in tandem with each other. What I was taught is FiO2, we're just going to titrate to pulse oximetry, and PEEP is really just a shot in the dark. Most people will give 5 a PEEP and then not really understand when they should move up from there. This takes the thought process out of the situation. So 5 minutes in, we drop them to 40% and 5 a PEEP, and then we're just going to assess pulse ox. And we're looking for a goal, according to ARDSNet, of 88 to 95% on a pulse ox. Scott Weingart in his lectures says that he shoots for exactly 90. I shoot for 94, not because I'm uncomfortable with having patients a little bit lower than that, because usually the people that we're dropping our patients off to aren't comfortable with a pulse ox of 90. So I just kind of titrate for the low 90s and 94 kind of being my end game. The whole point of that is we don't want to have oxygen saturations that are 98, 99, 100%, because then we're going to run into hyperoxia problems where their PaO2 could be 100 if they're 100%, or it could be 400. And high oxygen levels like that are going to cause vasoconstriction. It's going to make it harder for oxygen delivery because your body thinks, hey, I have all this oxygen going around, I can constrict and I don't need to help the diffusion of oxygen to my tissue. So I drop them down to 40% and 5 a PEEP. I wait about 30 seconds for my pulse ox to catch up, and I see where we're at. If we're 82%, then I know, hey, I need to move up on the PEEP scale. And I'm going to move up to 40% and then 8 a PEEP. So it's actually making me adjust my PEEP first. So I'll go up on 8 a PEEP, leave them at 40%, wait another 30, 45 seconds. If they're 85%, well, that's lower than my goal. So I'll move up another little rung on the ladder of the PEEP scale. And then I'll change my FiO2 to 50%, 8 a PEEP. And then 10 a PEEP at 50%, 60%, 10 a PEEP. So it's going to have you adjust them in tandem instead of just shooting in the dark, not knowing what we need to do with PEEP. This is going to allow us to have a structured and studied tool. The reason for the PEEP is once you get beyond 50% FiO2, the only reason that the patient could be hypoxic is due to shunt. So if they're shunting, if you give them more FiO2, it's not going to do anything to open up that shunt. They need higher mean airway pressures, and the way to do that is to give PEEP. So that's why this is so imperative to do and to understand. I said that there was a higher PEEP scale. They had a higher PEEP scale that before they got off of, I think, 50% FiO2, they were already up to 18, 20 a PEEP. So they rapidly titrated up the PEEP in that scale. And that scale actually was showing that is going to have benefit over the lower PEEP scale, but they chose to recommend the lower PEEP scale because they knew that people would be too uncomfortable with PEEP. So it was going to be a while before they could make that jump to a higher PEEP strategy. So what does PEEP do? It does some good things and it has some messes about it. The good things is it's going to improve ventilation and perfusion matching. So it's going to open up those shunts and it's going to get oxygen out to alveoli that otherwise wouldn't be ventilated. Clearly, it's going to decrease shunting. It's going to decrease atelectasis and atelectic trauma, which atelectasis is the closing of alveoli, and atelectic trauma is whenever they're rapidly opening and closing with every breath. And that is going to cause shearing forces over time and destroy them. And really is what causes people to develop ARDS. It's if you add PEEP to that, then those alveoli are going to maintain distension during exhalation, and they're not going to close up on themselves. And it's actually going to make spontaneous breathing easier. So whenever the patient is coming off of the vent, if they have PEEP and they already have distended alveoli, well, then it's going to be easier for them to finish that breath because there's already pressure in there. Imagine blowing up a balloon. The hardest part of blowing up the balloon is at the very beginning. You requires a lot of pressure to get that, to begin distension. If once it's already distended, it's really easy to blow it up from there. The bad things that PEEP does is it's going to decrease a little bit of venous return with that vena cava to the heart. So if we have the lungs a little bit more inflated than they would be without PEEP on board, it's going to allow less room for blood return to the heart. So patients going to require a little bit more volume, maybe some vasopressor support, which we're clearly accustomed to doing. The myths about PEEP that are true, it causes pneumothorax. It does not. What causes pneumothorax is these high tidal volumes that used to be the norm, which we're going to avoid, and we're even go further than that. We're going to check plateau pressure often in order to make sure we're not giving too high tidal volumes, and then people acting like if you give high PEEPs, the patient's head's going to explode. And that's just not what PEEP does. It doesn't cause an ugly mess. So tidal volume equals protection. Inspiratory time equals comfort. Respiratory rate equals ventilation. And finally, FiO2 and PEEP together are going to equal oxygenation. All right, so plateau pressure. There's a pressure that's going to be on your vent, and it's what's going to flash at you all the time. It's going to tell you that pressures are high, and that's going to be peak inspiratory pressure, the PIP. PIPs don't really tell us anything useful for the patient's alveoli. PIP is just going to tell us what's happening to the large airways, how much resistance it's encountering with the tube, the trachea, the bronchus, the bronchioles, if there's any secretions in there, if they have a pneumothorax, really anything that's inhibiting the breath from getting down to the alveoli. But it doesn't tell us what's going on at the alveolar level. Patients can have high peak inspiratory pressures, and they're not going to be harmed by that. It's whenever they have high plateau pressures that they have an issue. So we're going to do some plateau pressure checks. We'll go over what plateau pressure is first. The number you need to remember is 30. Less than 30 is what we're shooting for. If it's over 30, then we're going to have to do something to help the patient be more protected. So this is a pressure time waveform on the Zoll impact. This is the only waveform that you get. So during the breath, more air is going to go into the lungs, and it's going to peak. That very top portion is going to be the peak pressure, peak inspiratory pressure. Like I said, it's not really telling us what's going on with the patient's lung. It's just telling us what's happening in those large airways, and it might, clue you into suctioning the patient, looking for a mucus plug, maybe switching out the tube if needed, if it's too small. But it's not going to tell us anything that's going to really impact the patient when it comes to lung injury. The little spot off to the right before it drops down to 0, is the plateau pressure, and that's what we're shooting for. Most of the time, the pressure waveform isn't going to look like this nice little plateau. All it's going to do is it's going to go up and then rapidly drop off, and we're not really going to see this plateau phase unless we make the ventilator show us it. On ICU ventilators, they're all going to have an inspiratory hold button where you can go into the back settings and during inspiration just do an inspiratory hold. That's going to keep the breath inside the patient, and then that's what's going to show us an actual plateau. We don't have that function, so what we have to do is we're going to have to kink off the vent tubing. So imagine your vent tubing and then your little knob part that connects to the ET tube. When it comes off, it has an exhalation port off to the side that's not connected to anything. The most that it's connected to is a HME, so a little filter if the patient has TB or some other infectious disease. So usually it's bare down here, and the breath goes in through this inhalation section of the ventilator tubing, and then it doesn't come back through. It doesn't come back to the vent. It comes back to and out of this exhalation port. So at the end of the patient's breath, all you do is take your gloved thumb, kind of stick it in its hole, and then kink off this tube. And it's going to hold the patient's breath in. You're going to notice that your pressure waveform goes up, and then it's going to plateau out. And you're going to have some markers over here on the side, depending on how high the pressure is. It's going to give you like a random number like 36 and 26. And then your PIP is going to flash over to your right. So say your peak inspiratory pressure was 35 up here. Once it plateaus out, it's going to flash a couple times, and then it's going to give you your new pressure. So either you just eyeball it that it's less than 30, even though it doesn't give you a nice, easy way to see 30. You can intuitively see how high or low it is, but eventually it will show you a number after a few seconds. And then all you do is just release the tubing and go from there. The proper way to do a plateau pressure is to take 3 measurements about 30 seconds apart and then average them. And if it's over 30, then that's too high. When we're going to do plateau pressures, you should do it right whenever you put the patient on the ventilator to make sure the patient's still protected well, and then about every 30 minutes, unless your patient looks like they're decompensating and you need to, emergently check it. But anytime you're taking a patient on the vent, every 30 minutes is a good point to check. So what does that mean? Peak pressures mean nothing. Nothing of real importance to what's happening to the patient's lungs. I mean, it's useful in deciding that, oh, hey, this patient needs suctioned again, or maybe there's a mucus plug that needs to clear out, or hey, maybe they're developing some bronchoconstriction and they need some albuterol and atropine added on but it's not. It's all it's going to do is just alarm at you, and it's not going to give you the good information you need. You're going to have to go seek that out, and that's for plateau pressure. So what happens whenever our plateau pressures are over 30? Well, that's where we talked about tidal volume being our protective setting. So if we were at 8 mils per kg, um, we're going to just drop them down to 7 mils per kg, and then we're going to wait 5 minutes or so, and we're going to check another plateau pressure and make sure that they're less than 30 at that point. If they're still over 30 at 7 mils, then we're going to go to 6 mils per kg. After that, you should probably call medical control or the receiving physician. Just let them know that, hey, we're kind of dropping pretty low on our tidal volumes. The patient has high plateau pressures. We're going to drop them to 5 mils. Once you start getting below 6 mils per kg on your tidal volume, the patient's going to be hypercarbic. So they're going to end up retaining too much end-tidal CO2, and it might be an issue. It's something that we need to at least talk to a physician about before we do, but that's just what ARDS forces you to do, and it's what's going to be best for the patient. So in summary, for the lung protective strategy, tidal volume is going to be 6 to 8 mils per kg of predicted body weight, and we're going to change that whenever the patient needs more protection. So their plateau pressure is higher than 30, they're at risk for lung injury, we're going to drop that tidal volume lower. Second dial, inspiratory flow rate for us, just need to think about inspiratory time, so designated as TI. That's going to equal comfort. Most commonly, 0.5 to 1 second is where I'm going to keep my patients at baseline, and that kind of eliminates them having too long of an inhalation. Respiratory rate, you're going to need to factor what that tidal volume is. What the minute ventilation is for that patient based off of their size, and then divide that by the tidal volume. Almost always it's going to be 16 to 18 breaths per minute. That's a good place to start. And then FiO2 and PEEP, we're just going to use the PEEP scale in order to determine where we're at on that. So the downfall for emergency physicians in the strategy, it's not really a downfall, but something that's a little bit more tedious is if they're on a assist control volume and they're doing this lung protective strategy, they're going to need a lot of sedation. Not necessarily sedation, but they're going to need something to keep them comfortable. What that means is analgesia first. So we're going to give, very potent pushes of fentanyl, and we're going to get them down to, what's, you'd imagine picking up a heroin overdose is like. They're breathing, maybe a couple times a minute, or not breathing at all per minute, and they're very difficult to wake up. So we're going to get them nice and, almost sedated on analgesia, and then after that, we're just going to add on a little bit of sedation, that being, Versed, Ativan, propofol drip if we have them. That's the best way to do it. That's what's safest for the patient. Because if you try to do the opposite, which I still see a lot of people doing, is having like a propofol drip out of the ICU, and they're getting on high doses. We put them in our helicopter, and it's vibrating, it's loud. You keep having to amping up your propofol, and it just never seems like you get the patient really well controlled and where they're comfortable. After that, they might remember to throw on some fentanyl or some morphine or something, or they might just forget it completely. If you do analgesia first and give really heavy doses of pain medication or ketamine or ketamine drip, then they're going to be comfortable. They could have some level of awareness and be completely happy because the pain's controlled. After that, if you need a little bit to keep them, where they're not anxious, to where they're not really moving around, then you just add on a little bit of 0.5 Ativan, 1 milligram Ativan, or 1 or 2 milligrams of Versed, and it really limits the amount of benzodiazepines that we have to give. Because benzos are going to cause hypotension, and eventually it's going to cause delirium in the ICU for that patient. All right, so that was our lung protective strategy. 4 dials that we care about, pretty straightforward. Each one has a certain reason that we're going to adjust it, and nothing else really needs to change that. The second strategy is our obstructive strategy, and that's going to be for COPD patients or asthma patients with active bronchoconstriction. So they got wheezing, they have really high peak inspiratory pressures, and they get intubated because we have to get them from point A to point B, and it's not really safe to put them in a helicopter and keep them on CPAP or BiPAP. This is the hallmark of the do no harm, kind of idea for us in the medical industry. Whenever we put an asthma or a COPD patient on the ventilator, it actively makes them worse. The tube down the throat isn't going to do anything to make them better. We have to continue those medical therapies. So what's our goal for this strategy? The goal for the obstructive strategy is to give the patient enough time to breathe out. The patho behind COPD and asthma and this bronchoconstriction is they get the air in, but since those bronchioles are constricted, they can't get the air out of the alveoli and out to back out of the ventilator or just back out into the environment. So they start breath stacking, and it really wears them out because they're trying so hard to breathe out, but as they push air out, they're hypoxic and they're hypercapnic, and it forces them to start breathing again. And so they keep stacking. So we have to help them breathe out. So mode we're going to start with, just like the other strategy, we're going to give assist control volume. This isn't going to be a problem at all. There's no theoretical thought of SIMD or PRVC being a better strategy or mode for this, because these patients are going to require to be sedated heavily and probably still be paralyzed from the intubation, because we're going to need to give those muscles enough time to get rid of that lactic acidosis and to relax a little bit, because asthma is going to be the type 2 respiratory failure. That's going to be, failure due to them just stopping breathing completely, as opposed to type 1, which is a hypoxic condition. These patients aren't going to be hypoxic up until the very end, whenever they just can't take in any more volume and they just stop breathing. So they'll be out for a little bit, or they should be out. So assist control volume is going to be just fine for us to use. So we get back to our different settings that we're going to need to adjust. Dial 1 is going to be our tidal volume. And we're just going to give all these patients just 8 mils per kg of predicted body weight. They shouldn't have any issues. There's probably a need for us to discuss eventually patients that have obstructive pathologies that also have ARDS and or severe pneumonia. There's probably a combination that we're looking for those patients, but for just a straight bronchoconstricted patient, we're just going to put them on 8 mils per kg. Next dial wasn't super important for the lung protective strategy, but for this one, it becomes a little bit more of a treatment measure for us. So for lung protective, we were doing 60 to 80 mil or 80 liters a minute, or an inspiratory time of 0.5 to 2 seconds, usually 1 to 2 seconds for where most people start. For this, we're going to increase that a little bit. So if we give the patient the breath over a shorter amount of time, then that's going to allow a longer time for them to expire. So that's kind of helps us with what our goal was of allowing the patient enough time to breathe out. So setting our inspiratory time low is going to kind of help that goal. Third setting for our obstructive that we're going to talk about is FiO2 and PEEP. FiO2, again, shouldn't really be an issue for these patients. They have enough oxygen floating around. It's the fact that they just can't get the air out of their alveoli. So we're just going to titrate between 40 and 100% based off of whatever that pulse ox is, with the same goal of 94%. PEEP, we're just going to set the PEEP to 0. The reason for that is because they can't get air out of their alveoli. We're going to leave the PEEP at 0 because they already have some form of auto PEEP going on. And adding PEEP to that might make it deleterious for the patient, where it causes that pneumothorax combined with the tidal volumes that we're giving. So for this strategy, FiO2, set it to whatever you need it to be, and then PEEP, just leave it at 0. There's people out there that talk about, theoretically adding PEEP to these patients, a little bit, 1 to 5, is going to be useful because it might help stent open the bronchioles to allow air to come out. But you're going to do more harm than good. And you're not really going to know which patients it might help and which patients it's going to, hurt or possibly kill. So just set that PEEP to 0. Fourth dial, respiratory rate. This is the most important setting for this obstructive strategy in the patients that you're going to encounter with this. Arguably, tidal volume would be the most important setting for the lung protective strategy. Respiratory rate is going to be that most important setting for our obstructive strategy. So the idea, the reason that it's so important is respiratory rate is going to be protection for these patients. And it's going to be because we're going to set the respiratory rate really low, a lot lower than they would need to maintain eucapnia or to blow off CO2. We're going to set it to 10 because we're looking to give them all the time in the world to blow off that air that's stuck in their alveoli. So if we tried to give them respiratory rates at 16 or 18, like we talked about earlier, what they would need for the tidal volume we're giving, they would start stacking on breaths and eventually causing pneumothorax. So while the patient is still acutely bronchoconstricted, we're just going to set the breath rate to 10, and we're going to allow them to be hypercapnic for a little bit. We're just going to allow that while we add on the albuterol adjuvant through the vent tubing. We give them epi-IM, maybe we give them magnesium, or we throw on some corticosteroids, and we continue those medical therapies that are so important to fix the bronchoconstriction. Until we get rid of that, we're just going to let them have high end-tidal CO2 levels. So what that's going to do is you're going to see your IDE ratio get really, really long. If you set them on an in-story time of half a second and breath rate at 10, they're going to get that breath over half a second, and they're getting 10 a minute. So that's just going to be 5 seconds out of the 60 for the minute is when you're going to get inspiration. So for 55 seconds a minute, they're going to have time to get that air out. So for starting out, we're just going to set our IDE, or we're going to monitor our IDE after we set our respiratory rate at 10. And we're going to make sure it starts out at about 1 to 4, 1 to 5. If we think that the patient is breath stacking, say you get an alarm that says incomplete exhalation, the patient gets hypotensive, they look like they're decompensating, then what we're going to do is we're going to just extend that IDE time out even further. So 1 to 6, 1 to 7, 1 to 8, however long we need to go out to make sure that they're not stacking breaths. So this is what breast stacking looks like if you had a flow time graph. So the red part, that's our inspiration, and then it drops way low during expiration and begins to come out. The dotted line is what a normal expiration would be. It ends nicely before this next breath begins. But in bronchoconstriction with air trapping, expiration takes a really long time and they don't get it all out. And then that next breath starts and they're already have air still remaining in their lungs. So every time this happens, it adds more and more air into the lungs until eventually it causes a pneumothorax. So again, peak pressures, they're going to be nothing. They're going to be screaming at you for these bronchoconstricted patients. You know, they might have peak pressures of 50, 60, 70. And it's not really a big deal because it's just reading that bronchoconstriction and the secretions or a mucus plug. We're going to have to go and measure the plateau pressure again. So we're going to measure the plateau pressure by clamping off the exhalation port and assessing if it's over 30. If it's over 30, we're not going to adjust tidal volume in these obstructive patients. What we're going to do is either lower our respiratory rate or extend our IDE timeout. So you might lower your respiratory rate down to 8. Less than 8, that's where you need to start talking to a physician again. They're probably going to be fine if you lower them down to 6. They're not going to, become hypoxic, but it's really going to drive up their end-tidal CO2. Main thing, they're going to have to just be permissively hypercapnic for the short term. We're going to add on all our medical therapies and give them as much albuterol and adjuvant as we can give. And hopefully that will start to lessen their bronchoconstriction and they'll start to get air out of those alveoli. But for the short term, before that stuff happens, then they just have to remain 60, 70, 80 on their end-tidal. Because if we start trying to blow that off with respiratory rate or with tidal volume, if you were still trying to use that strategy, then eventually we're going to cause a pneumothorax. And that's obviously something that none of us want to deal with, especially if we induced it. Patients are going to tolerate the hypercapnia just fine. They're going to need more sedation and a little bit more pain control. But you can drive down their pH a little bit. Usually 7.0, 7.1. If we were monitoring it in the field, patients are going to do just fine. So that allows us to have a end-tidal of 60, 70, 80 and not really be an issue for the patient. So those are our two strategies. You have lung injury. That's going to be for a majority of patients, except for ones with active bronchoconstriction, and then we're going to use the obstructive strategy for that. There's just a couple of alarms that are going to pop up on the vent that you just need to know what the causes are. So low exhaled volume, that's where we're going to have to assess for breath stacking, so the air trapping kind of thing, because if they're not exhaling that air that you put in, it might be an issue. It could also be because of a cuff leak or rupture where air is escaping out on the sides of the tube. And so your ventilator is not receiving it back to monitor how much came out, or a bronchopulmonary fistula where they're losing air from another source inside the lungs. High minute ventilation, there shouldn't really be an issue as long as we're sedating and keeping them well pain controlled, but that's going to be hyperventilation, be normal in a hypermetabolic state like aspirin overdoses or DKA, or if they don't have enough tidal volume and the patient has some level of awareness, they're going to try to breathe more and more to try to meet that minute ventilation demand. Low O2 pressure, that's just going to be if your bottle starts to run out, so make sure your connections are tight, tank's full, and the tubing's connected appropriately. Apnea alarm was probably just going to yell at you first is your end tidal CO2 on the monitor is going to tell you, 8 seconds after they stop breathing that they haven't taken a breath in a while. But your vent also does it, 20 or 30 seconds without a breath. If you're in a spontaneous mode, then it's going to let you know. High peak and story pressure, we've already talked about. What's going to cause that is secretions, mucus plugging, bronchoconstriction, and then pneumothorax. So just kind of roll through your mnemonic, make sure it's not secretions or a mucus plug. Listen to the lung sounds if you're not in the aircraft. If they're a patient that already had bronchoconstriction, give them albuterol and adjuvant. And if they look really bad, then you would need to consider popping the chest for a pneumothorax. And then low peak and story pressure, that's just going to be disconnected tubing or misplaced airway or the tube coming out of the trachea and into the stomach. So we'll just do a couple practice examples, and I'll try to write on here where it's legible. So we had a 5'4" female patient with asthma. So we have asthma. We'll just assume that she is being intubated because of the asthma. So she has severe wheezing. She just stops breathing on you. So 5'4", which you get to see my notes out here that I already did. That's 64 inches tall. So for our tidal volume, we're going to have to figure out what predicted body weight is. So our tidal volume, remember, we're going to do 8 mils per kg for the obstructed strategy. For our predicted body weight, so 64 inches, that's 4 inches over 60 inches. So 4 times 2.3 equals 9.2. 9.2 plus 45.5 equals 54.7. So we're going to go with predicted body weight of 55, round up. So 55 times 8 is going to give us a tidal volume of 440. So 440 is our tidal volume. Inspiratory flow rate, this is the obstructive patient, so that's going to give us, we'd want an inspiratory time of about 0.5. Respiratory rate, we said it's going to be 10. And then FiO2 and peak, we're going to give a peak of 0. And then FiO2, we're just going to give whatever the patient needs to maintain a pulse ox of 94%. Say we put the patient on these settings, we check a plateau pressure and it's 25, so we know that our respiratory rate's still appropriate. We're going to give maximal therapy for bronchoconstriction, albuterol, adjuvant, epinephrine, magnesium, steroids, and then we'll start transporting. Say during transport, you look up to the monitor and the patient's now 60 over 40. First thing you need to do is disconnect the patient from the ventilator. So take the vent tubing off and just leave a bare tube, and hopefully there will be a big rush of air. And what happened is the patient breath stacked without you knowing it. Maybe they got a little bit worse and we didn't realize it. And they got really hypotensive due to the increased interthoracic pressure and decreased venous return. So you just pull off that vent and it's going to allow them enough time to breathe off, and then we would throw them back on the ventilator with adjusted settings. So we decrease our respiratory rate a little bit and make sure our medical therapies are appropriate. So next example, 6-foot male with pneumonia. So we'll assume that he doesn't have any other pathologies going on. It's just, severe bilateral pneumonia. So we're going to give him the lung protective strategy. So we get a 6-foot male, so he's 72 inches. That's going to be 12 inches over 60. So 12 times 2.3 equals 27.6, and plus 50 equals 77.6. So we're just going to go with 78 as his predicted body weight. Doesn't matter what his actual weight is. This is what his lungs are used to, 78 kilograms. And then we're going to start at 8 mils per kg. So 78 times 8 equals a tidal volume of 624. This is lung protective, so our inspiratory flow rate or inspiratory time isn't that big of a deal. We're just going to start him off on 1 and see how that goes. For respiratory rate, we just need to do 120 times 78. That's going to give us 9360. And we're going to divide that by 624. And that gives us a respiratory rate of about 15. So that's where we're going to start. So we're going to say we intubated this patient. We're going to put him on all these settings. We're going to put him on an FiO2 of 100% and a PEEP of 5. We're going to give him a couple minutes to get used to that, let his pulse ox come up to 100%, and then immediately we're going to drop him down to 40 and 5. Give it another 30 seconds or so, see where his pulse ox goes. If his pulse ox is now 77%, then we're going to move up. So from 40 to 5, we're going to go up to 40 and 8. Give it another 30 seconds. If it's not at our goal, we're going to move up again. That's going to be 50 and 8. And then 50 and 10, 60 and 10, 70 and 10, 70 and 12, 70 and 14, etc. It moves up from there. And that's pretty much how that lung protective strategy goes. Pretty simple. Just know, so say we did a plateau pressure on this patient and it comes back at 35. Well, that means that we're going to have to factor all this stuff again. So I get my calculator out, which is what I always do. So I'm going to do 78 kilograms, 78 times 7. Now my tidal volume is going to be 546. 120 times 78 equals still 9360. So 9360 divided by 546. Our new respiratory rate is going to need to be around 17. Again, we get them going. We check PEEP and FiO2 again, make sure that's where it needs to go. And we get another plateau pressure and it comes back at 40 this time. So even higher. This patient's getting a lot worse. Well, then we would drop them down to 6 mils per kg tidal volume. So 6 times 78 equals 468. So 9360 divided by 468 equals 20 now. So each time we adjust tidal volume, we're going to have to go up on our respiratory rate in order to maintain the end tidal level that we want. So finally, our last example, something that we didn't really discuss, but there's not a whole lot of great evidence on where to start with these patients. So imagine we get a 2-year-old patient with heart failure from some congenital heart defect. Predicted body weight doesn't really go down that low. It's really, for men, 4'10" is as low as predicted body weight really is useful. And then for women, I think it goes down to 4'7". It usually isn't an issue with people shorter than that, because people shorter than that are usually pediatrics. And we would like to imagine that pediatric patients are all going to be whatever ideal body weight they should be. But with childhood obesity happening, we're going to have to start making sure our tidal volumes aren't too large based off of what their actual body weight is in the future, especially likely to get a lot worse. So for a 2-year-old male, let's pretend he's 14 kilograms. 14 times 8 is going to be 112. So tidal volume of about 112 is where we're kind of going to want them to be. Inspiratory flow rate, all kids get like 0.4 to 0.5 to 0.6, so pretty quick because their respiratory rate's going to be pretty fast. 2-year-old, our normal rate's going to be just 20 to 30. Not really a good way to calculate respiratory rate for pediatrics because they just require a little bit higher respiratory rate because they have increased oxygen consumption, a lot less of an oxygen reserve. And then PEEP and FiO2, we're just going to do the same scale. They shouldn't really need much FiO2, much PEEP unless they're severely decompensated in a critical state. The way that most pediatrics end up being placed on the vent is on a pressure mode. So what that means for us is we're going to set this PIP and we're going to set it to 16 to 25-ish. And that's going to make sure that we don't give too high of a pressure to a pediatric patient. But it's going to force us to continually monitor what our tidal volume, because each breath is going to give you a new tidal volume. And we want to make sure that whatever pressure we set, they're getting adequate tidal volume at that pressure. So if I set a pressure of 20 starting out, my tidal volumes are all 200, I'm going to say, oh crap, that's way too high. Let's drop them down to 18, and then I'm going to monitor from there. Maybe go lower and lower until I get the tidal volume I want. So it doesn't really matter. Just like I said with adults, you could set pressure, you could set volume. It doesn't really matter because we're just going to monitor both. Anyway, that's going to be the conclusion for the vent management lecture. If you have any questions, please reach out to me. If I said something that you don't agree with, then feel free to call me out on that. Besides that, go find the MCRIT podcast that I talked about, Dominating the Vent Part 1, Dominating the Vent Part 2. Go read all the evidence. I didn't lie to you, but it's always good to go assess it for yourself. And call me up and ask if anything comes up. If you have questions about how this gets implemented out into the field, I'd be happy to answer any questions. So thank you. Have a good day.